Over the next 20 odd minutes, I will give a brief overview of how we have taken from personal genomes to populations and from populations back to individuals. Before I start my talk, of course, there are a list of mandated disclosures that we need to make because we work with a large number of companies, both pharmaceutical as well as diagnostic companies in India and abroad. Now, to give a brief premise of why we are talking genomics here is also because genomics is largely accelerated in the last 2 decades. And most of this acceleration happened in the decade that followed the draft reference genome sequence. And we were fortunate to be in the right place and probably in the right time. And that is also because the cost of genome sequencing and the throughput of genome sequencing was significantly improving over the last decade or so. Now, I'll take you back to the year 2008 when, of course, the human genome was available. And of course, there were a large number of other genome programs, including the rise of Drosophila and, of course, human genomes of multiple dimensions happening across the world. Now, while this was happening across the world, what we should also keep in mind is that way back in 2008, there were only 6 genomes that were available. And all the 6 genomes came from quite less admixed populations across the world. Now, this came from the European or the East Asian ancestry or African ancestry. But the largest populations that you see, which are most admixed and contribute to almost a third of the global population, had no genomic representation. And that's when we started trying to look at genomic sequences from these populations which span the Middle East and the Central and Southeast Asia. Of course, the idea of doing the first genome was also to learn the tricks of the trade because there are very few countries and very few groups across the world which could put together a genome sequence and assembly and analysis in terms of the clinical interpretation. And of course, in a year's time, we were fortunate to be able to do that. And this was announced in 2009 by the Honorable Minister in the Parliament. I'm sorry, my slides are behaving a bit abnormal. Yeah, and from there, we took it forward to essentially looking at the diversity across this region from the Middle East to Central and Southeast Asia, widely collaborating with a number of countries, in many ways also contributing to the genomic programs, so the start of the genomic programs in many of these countries. This includes Sri Lanka, Malaysia, and very recently, many countries in the Middle East. They're also the founding partners of the Pan-Asian Population Genomics Initiative, which was one of the flagship programs of the Human Genome Organization, trying to understand the genetic diversity of this large admixed population in the world, encompassing almost a third. And today we hold a large number of databases and datasets in the lab, which includes and catalogs the diversity of these regions, including the Southeast Asian region, the Middle East, and very recently, the Indian subcontinent. Now, what are the applications of doing this genomes? It is not about just showing that you can do a lot more genomes, but also to understand what can be really the applications of this in clinical settings. And one of the applications that we sort of initially thought about of genomics is to essentially understand rare genetic conditions. Now, while these rare genetic conditions are individually rare, cumulatively, they encompass a very large number and estimated to be around 70 million people across India and 300 million people across the world. And that's quite a large number because that pretty much is the size of many modest-sized countries in Europe and in Asia. Now, the problem with these genetic conditions is that since they're extremely rare, they go through multiple rounds of misdiagnosis, and a significant large time is lost to patients and families in their attempt to sort of arrive at a diagnosis or a molecular diagnosis. Unfortunately, today, a significant large number of these conditions are treatable. And that's essentially an opportunity that is now lost. So way back in 2015, we put together this program with the idea that we can do this in India. And the idea of doing this in India is that we are a very large population of around 1 billion people, or approximately a sixth of the world population. And unlike other large countries, our population is very diverse and stratified into small endogamous groups. So many of the other large global populations are quite homogeneous and less admixed populations, as I told before. But India is very unique in this aspect because they're endogamous groups because of very peculiar marriage practices within these families. And even more importantly, the families in India has not seen large-scale displacements due to war or due to famine, And therefore, we still have a close-knit family structure and an extended pedigree, which could be drawn for many of these families. And all of genetics, I would say, starts with an extended pedigree, and that therefore there's an opportunity at hand. So with my colleague Sridhar, in 2015, we started this program called Guardian. Guardian stands for Genomics for Understanding Rare Disease in the Alliance Network, which was pilot funded by CSIR and continued over the last decade or so. And through this program, what we do is we work extensively with clinicians, and today we work with a large number of clinicians from almost all major centers across the country who refer undiagnosed conditions or familiar undiagnosed conditions to us, which are put together through a standardized process of sequencing, analysis, interpretation, and reporting back to the clinician so that they can act upon it. And of course, this happens only in around 50% of the cases. The rest 50%, we really do not know what causes these diseases. So we really step back into the lab to understand these diseases at great depth by doing extensive expeditions in trying to understand the molecular pathogenesis. And with the idea that a significant large number of them we can actually return back to the clinician with a new diagnosis or possibly a new gene. And this is now impacted close to around 5,000 odd families annually, increasing to around 2,000 odd families every year. And it is not just about diagnosis, but also to educate clinicians, to empower them, and of course, to implement policies based on evidence across the country. And for people who are really interested in this program, there is an overview that we wrote of our last 4 years of the Guardian program. I'm sure many of the people in the audience are authors in this particular paper, but if you're not, you could have actually a good read. Now, how does this program work? And this program works because a large number of undiagnosed patients either come to us through the clinicians or actually go through governmental agencies asking for support. And this is one such family from a very close by state of Uttar Pradesh in Agra. And this family actually petitioned the President of India with permission to euthanize their 6 kids. Now think of the plight of a family who would ask a petition to euthanize their own kids. And that's largely because these kids have a progressive neurological disorder without any diagnosis and without any hope. Now, through the genome sequencing program, we did identify this genetic mutation in a gene called the MLC1 and confirmed the diagnosis called megalencephalic leukoencephalopathy with subcortical cyst type 1, a mouthful of a name, but in common parlance also called as cystic megalencephaly. Now, this condition is extremely rare, and of course, the other mutation for this particular condition was also a founder mutation identified from India in the Bansal Agarwal community. So this becomes the second mutation of its type identified from India. Now, there was indeed another report of a patient who had this genetic mutation with a Persian ancestry. So we were really interested in what is really going with this particular family. So we went ahead and did an extended family survey of around 100 odd individuals. And what we found was quite surprising. For this extremely rare genetic mutation, genetic event, we had approximately 28% of this close community were carriers for this genetic mutation. And we identified another 4 families with children suffering from this extremely rare genetic condition. And all of these individuals belong to one close endogamous group called the Nalband community, also making this mutation another founder mutation identified from India. Now, from the 5 case referral to diagnosis to the publication to today a diagnostic in the market, which can now be benefiting almost 5 lakh people of this community, we have actually covered the entire spectrum of activities that needs to be done in genetics. And this is possible with close collaboration with All India Institute of Medical Sciences, Professor Shefali Gulati, who heads the pediatric neurology department there. Now, of course, these are not uncommon cases. When this is another case from CMC Vellore. This is when Dr. Sandhya, who is also fortunately my wife, was in CMC Vellore. And this is a case which presented with recurrent fever in an adult. Now, this individual had periodic fever over the last 5 years and has gone from pillar to post, taken all kinds of antibiotics, taken a full course of antitubercular treatment, but nevertheless, the fever and the episodes of fever never came down. Now, when you have such conditions, typically one of the last differential diagnosis is a condition called periodic fever, and one of the commonest periodic fever is a condition called familial Mediterranean fever. And this is because of genetic mutations in the MEFP gene. And therefore, a confirmation of the genome sequence could provide a molecular diagnosis and, of course, an accurate treatment for this particular condition, because this is a treatable or a manageable condition as far as the condition goes. So in this particular family, as you see here is a prosentergamous family, we did find a genetic mutation. And more importantly, this genetic mutation, as its name signifies, familial Mediterranean fever, is very prevalent in the Mediterranean basin of the world. Where this variant is quite prevalent in the population, approximately 1 in 8 individual is a carrier for this genetic condition. So we're very suspicious, why did this individual get this particular genetic mutation? So therefore, we could actually go back to the genome sequence and trace the ancestry of the individual. And what we show here is that this individual indeed had a mixed ancestry of part Persian and part Indian. Or in other words, this is an admixed individual of 2 different ancestries, and therefore this signifies that the ancestors of this particular individual had migrated from the Mediterranean basin many years ago. Now, if you really see these 2 cases, there's a common thread in these cases. You have conditions which are affecting individuals in India, but nevertheless have been discovered elsewhere in the world. Now, why should this happen? And if you think that this is a rarity, in many cases it is not, because over the last 10 centuries, we had a close connect with the Mediterranean basin. There are people who have come in as traders, who have come in as friends, and much later have come in as invaders, but nevertheless, they have all come into and got assimilated in the milieu of India. They've all been Indians, but nevertheless, having a small portion of the genome which they brought from where they came from. And when they brought the genome with them, they also brought a specific set of genetic mutations which could cause diseases which are prevalent in a different part of the world, but now occurring in small populations across India. Now, this is just a small representation of such populations. There are many more populations which trace their ancestry to the Mediterranean basin, or largely what we call as the Middle East. Sorry for that. Yeah. Now, while we say this, we'll also need to come to the paradigm that all what we do has always been in collaboration with clinician. Or in other words, we always trust what the clinician is able to identify. And we still do trust what the clinician is able to identify. But what if the clinician is not able to identify a genetic condition, right? And that is pretty much true in a large number of conditions. I'll give you a couple of examples as we come forward. Now, how do we identify conditions that clinicians cannot identify? And that's a bigger question to answer. And the only way to answer that is if we could have evidence onto normal individuals or overlaid on normal individual genomes and ask the question, are they prevalent in the population, or are diseases prevalent in the population, and actually use this information to go back to clinicians, educate them, and look for such disorders very specifically. And of course, this is much easier said than done, because being a clinician, trained as a clinician, I know how resistant the clinical community would be if you were to teach them and say that this genetic condition exists. You really do not know how to look at, and probably this is a new way to look at. But of course, over years, what has also happened is, thanks to the technological advancements, genome sequencing is probably surpassed in terms of scale and time the standard of care, which was whole exome sequencing. And it has much more applications beyond whole exome sequencing, just because it is becoming faster and it's becoming cheaper. And one of the applications that is going to emerge in the very near future is where you could sequence sick newborns in the ICUs in a quite fast turnaround time. I'm not saying to sequence all newborns, but at least the sick newborns where you don't have a diagnosis. You could also use this approach for many other genetic conditions for families. You could do it for carrier screening when the diagnosis was not arrived at in case of a sibling death. But even more importantly, whole genome sequences encompass all genetic mutations and all types of genetic mutations. In other words, it is all genetic tests and more. I'll give a couple of examples, but before that, to do this, what we need to also have is to have a baseline data of the global population around us. And that's when in 2019, with my colleague Sridhar, we started this program called Indigen. The idea was to essentially look at 1,000 odd individuals from cosmopolitan populations across the country, try to understand the baseline frequencies of genetic mutations, and now go back and create applications which would impact public health. I have a couple of slides in the future, and the idea is to essentially look at very specific genetic conditions, look at, for example, pharmacogenomic genetic variants, look at population-specific genetic diseases, with the idea that every one single individual in this particular cohort could represent almost 1 million individuals in the country, because we are a billion population. Now, one such example is what I'm going to describe. This is from the Government Medical College in Calicut, where I studied. We started a program on primary immunodeficiency disorder because we did find a quite large carrier frequency in the population. And over these years, we actually have built a diagnostic option, a genetic diagnosis in terms of molecularly arriving at the diagnosis. We have started a specialized PID clinic and diagnostic support in association with the government, and of course further treatment through IVIG and hematopoietic stem cell transplants now available to these families and children who turn positive. And this was created with collaboration with Dr. Geeta Govindaraj, with a professor in pediatrics in this college. And over these years, we have benefited a large number of people through genetic diagnosis, through treatment, and in many ways through curative approaches like hematopoietic stem cell transplants. This is another such cohort that we built in Tirunelveli. There are many more cohorts that we built over the last couple of years. And this is essentially to also signify the value of doing whole genome sequencing. Now, this is a disorder which doesn't have a name. We call it familial adult-onset myoclonic epilepsy. If there are epileptologists in there, I'm sure that doesn't really figure in the guidelines for epilepsy. But this is a small community in Tamil Nadu who suffer from this genetic condition. From whole genome sequencing, we did identify the genetic mutation, a new type of genetic mutation, which is a pentad nucleotide expansion in a gene called SAMD2, and becoming one of the first characterized cases in India for this particular genetic disorder. Now, this genetic disorder is extremely rare. There are only around 34 cases reported in literature. Even the gene was identified only 3 years ago. But today in the country, in this particular population, we have 434, as of today, characterized individuals for this genetic disorder, and probably many, many more undiagnosed patients in this community. So we built a very cost-effective test, and we went into the community trying to educate them with the idea that now we could impact a community size of around 5 lakh individuals with a very cost-effective and point-of-care genetic test. And this was done in collaboration with Dr. Radha Mahadevan, who is a professor in neurology at the Tirunelveli Medical College. Now, while we do this, it's also very important to actually build tools and techniques to communicate this information at scale, because genomics is a field where evidence is changing almost every day. A variant that you had identified as pathogenic may not exist to be pathogenic today, and vice versa. So you need to have tools and techniques to provide updated information to both the clinician as well as the patient under his care. And one of these techniques that we have employed is to have a digital way of connecting the genomic evidence back for clinical implementation. And this is what we call as the Indigenome card. There are close to around 1,000 individuals today who have this particular card and could access information in conjunction with the clinician at point of care. And over these years, what we have tried to create is to create an ecosystem for clinical genomics in the country, starting from looking at patients and working with clinicians, enriching them through education and training programs, and providing very cost-effective genetic tests. While doing this, also creating value to the healthcare and diagnostic industry, and also adding to research in terms of rare genetic diseases and diagnosis. Thank you very much, and I'll stop here, take questions.